leaders, as neighbors, as colleagues, it is time to turn to one another, to engage in an international search for human goodness. In our meetings and deliberations, we can reach out and invite in those we have excluded. We can recognize that no one person or leader has the answer, that we all need everyone's creativity to find our way through this strange new world. I'm Joya Jefferson Nuri, and that quote was written by Margaret Wheatley. She published a piece in Shambhala's Sun entitled, "Remember the Human Goodness." It was published in September of 1999. It is a very fitting piece for us to start this profound conversation. In this profound conversation, we welcome you today, and we hope you will join us for this hour and our coming shows. Today's topic is centered around trust and ethics. We all know that we live in an age where trust is hard to find and ethics are questionable on so many levels. But today we're going to look at it in specific areas. We're going to identify trust and ethics from leaders in the DEI community, in the organ transplant community, and at one of the most renowned hospitals in the world, Johns Hopkins. We're going to divide this program in first determining what is trust and what actually is ethics. We're then going to move into that area of trust and ethics in organ donations, and then the COVID vaccine. I want to introduce you to our illustrious panel today. We are first being joined by Lesley Compagnone. Don't mind pronouncing your last name wrong.
Very close. It's Compagnone.
Compagnone. I'm so sorry.
Okay.
Lesley is the Director of Community Affairs at the Washington Regional Transplant Community. Next is Linda Howard. Linda is CEO of Alternative. Linda is a diversity, equity, and inclusion CEO. She also works on multicultural competencies, and she's a strategic advisor. Thank you, Linda, for joining us today.
Thank you.
Listen. Finally, Dr. Joseph Carrese. He's a professor of medicine at the Johns Hopkins Hospital and is a professor at the Berman Institute for Bioethics. Thank you all for being here today.
Thank you.
I want to start out with Dr. Carrese. Dr. Carrese, bioethics is part of your wheelhouse. You do work for Johns Hopkins, which is respected around the world. When a patient comes into Johns Hopkins, what should he or she expect in terms of trust?
I think that's a really important question. I'll come at that from the perspective of what I do, and I'm a primary care doctor. So I take care of people. I have the luxury of taking care of people over time and having a longitudinal relationship with them. And I see trust as at the center and at the heart of what I do and my connection with patients. Without trust, we don't have a functioning, robust therapeutic relationship. Without trust, patients may not come to see me, or if they do come to see me, they may not feel comfortable sharing sensitive information that needs to be shared in order for you to make an accurate diagnosis and give proper treatment. So it's really essential to the doctor-patient relationship. I think all healthcare provider-patient relationships, but as I see it as a primary care doctor, it's impossible to function without it. And I think the way ethics enters into that, I think of ethics as having one way of looking at ethics. It's a huge field, but clinical ethics, dealing with patients and family members, certainly starts with respect, respecting patients as persons, respecting their dignity, and taking into account how they think about respect, how they define respect, what it means to them, and operationalizing respect in a way that takes them into account. So I think that having that in place helps people trust us. If we don't respect them in a way that's meaningful to them, if we don't try to benefit them in a way that's meaningful to them, if we don't try to protect them from harm in a way that makes sense to them, then it's going to be hard for them to trust us. And as I said earlier, that's a sort of a starting point and an essential part of the relationship. I could say more about that, but maybe I should stop there and see what.
Well, I have a follow-up question. You said meaningful to them. I like that phrase. How would a doctor know what's meaningful in this trust relationship? What's meaningful to me when I sit in your office?
Yeah. So I think, and the reason I say that is one of my formative experiences as an early physician was spending 4 years in the public health service in the Indian Health Service on the Navajo Indian Reservation, and going to a community that I had no familiarity with, and obviously a completely different cultural perspective. Traditional Navajo individuals have a completely different worldview than I grew up with and that I was taught in medical school. Mm-hmm. And I stumbled along for several years, not saying the right things, doing the right thing. So I think the answer to your question is, how do you know what's meaningful to a patient? You ask them. You start with you don't make assumptions. And the starting point is, you teach me, let me learn from you what makes sense to you, what's important to you, what you value, how you understand benefit, how you understand harm, how you understand respect. So I think that's the starting point, listening.
Thank you very much. Linda, I'm going to ask you the same question. In the work you do, define the word trust. How does trust show up in your work?
Okay, so I've worked in the healthcare industry for probably about 15 years now. The majority of that experience was on the compliance side, working in healthcare compliance. Over the last few years, I've shifted to work more around multicultural competency and diversity, equity, and inclusion. And so just to kind of, talk a little bit, getting into Dr. Carrese's space, when you start talking about trust in the healthcare industry, you have to look at trust and even defining trust from a cultural perspective, and looking at, that trust relationship. And oftentimes for a lot of patients, for a lot of individuals in the healthcare industry, when you don't see people that look like you, it becomes very difficult to trust. And so having that diversity even in place is a key element to trust. Because if as was said, that, how do you look at someone in your space and say what's important to them? Well, one of the things that shows that you're important is that you have some people in the space that look like you and that can understand you. So, one of the things that I say oftentimes is that you cannot talk your way out of what you behaved your way into. Being in a trust relationship means that you have to actively gain that trust. It's not something that's just given. And in this country, we do have a history, even in the medical profession, of not having trust. That trust has been violated over the years, over decades, over centuries. And so with trust, it has to be something that's actively worked at. It is not something that you can just define and say, hey, you should trust me because I say you should trust me, but it is something that you actually have to behave your way into. So I think that we have a lot of work to do in the industry in order to gain trust.
Yeah. One of the things that Dr. Carrese said was that he went into a Navajo community. Obviously, he does not have a Navajo background, yet he gained the trust. If you're in a situation where you are not, you're the practitioner and you don't look like the people you're servicing, how do you gain that trust?
And I think that's a part of the work around multicultural competency, is being able to learn how to listen, learn how to understand, like not going in and saying, I want to help you from my worldview, but understanding what what help means to that person. What does health mean to that individual? What does it mean in a cultural setting? And so when I talk about not having someone that looks like me, that doesn't mean that the individual practitioner has to look like you. But if I walk into Johns Hopkins and no doctor looks like me, and no nurse looks like me, then I am going to question whether or not this is an organization that I should trust. Mm-hmm. So it's not necessarily that individual, but it's actually the organization. And I think individuals can learn to listen and understand and ask the questions and find out, what can I do in order to help you? And not look at it from their perspective, but look at it from that community's perspective.
Okay. Thank you, Linda. Lesley, a same question to you. And if any of our audience members wants to know more about each one of our panelists today, you can go to our website. If you're on the line now, you can probably go to the chat. When you go to our website and their full bios are there. Lesley, the same question to you in the area of organ donation. You are the Community Affairs Director of the Washington Regional Transplant Community, and trust in transplants has been an issue for millions of years.
Exactly.
It feels like
exactly.
it, right? So what does it mean to you?
Trust in what we do is absolutely everything. If we don't have it, the system breaks down, because we are part of the healthcare industry, that Linda and Dr. Carrese were talking about. We are one small cog in that massive wheel of the nation's healthcare system. But our little wheelhouse is judged even a little bit harsher because of the rarity, the complexity, the myths and misconceptions of organ donation. And there are so many to make that one miracle happen. There's so many people involved. And we just have to kind of throw our blind faith and trust into the hospital system that we're working with, the families that are in the worst moment of their life. Why should these families trust us, right? Why should these families trust it in the absolute worst moment of their life? We're going to come in and we want something from them, right? That is often how it's perceived. Oh, there's the organ donor people. I knew that they were just going to let my husband die because they want his organs, that type of thing, or there's a bad car accident and the EMT, no, he's not going to work to save my life because they want my organs. So we're starting there with a lot of perceptions. And I loved what Linda said, is you have to behave your way into trust. And that's what we do a lot in organ procurement, is we have to listen. We have to meet people where they're at. We can't come at it from our worldview and just pretend to understand how everybody feels in this situation. If those families that we are working with don't trust us, we aren't going to go anywhere. We just are not going to go anywhere. Because, you are dealing with the worst day of their life, all the emotional complexities that come with that. And then on top of that, then we're coming in to ask them for something. We're asking them to have somebody else live. Your loved one died, but someone else can live. How do you turn that around? How do you make them see the benefit of that at the worst time?
Yeah, I can imagine how that is a horrifying thing, and that is absolutely at the core of trust. And I do like what Linda said. You have to behave yourself into that trust. Dr. Carrese went to live with Native Americans. He had to behave himself into that trust. He couldn't come say, yes, but I'm the great doctor, and you must do it this way. It was listening. And I guess listening is at the core of any relationship, especially when lives are on the line. I want to move us into our next segment, organ donation. And I have a question for you, Lesley, to kick this off. That stereotypical answer around African American communities that I got all the time, even when I went to be an organ donor, it's on my driver's license, I'm an organ donor. And I had tons of people say to me, oh, they're going to let you die in the car accident, or, you're going to go in the hospital and somebody needs your eyes. And I thought, well, really, if the rest of me doesn't work, I actually don't want to be plugged in. That's my personal choice. And I've made that clear with my family. But that is something that is prominent. And you look at the Tuskegee experiment, you look at a history of medical abuse around African Americans. Why should this generation feel any differently?
Right. Well, the first thing is those immediate feelings and reactions are based in reality. Some really bad stuff happened, and we have to understand that. And I'll just be frank, as a white woman, I need to educate myself on that. I have to understand that. I have to understand where, Linda was talking about meeting people where they're at and understanding that background. There's Tuskegee always comes up. There's Henrietta Lacks on the research side. A lot of times we'll ask if the organs aren't viable for transplantation, there are research projects that can be, a diabetic pancreas can go for research for diabetes and hopefully one day find a cure for diabetes. But are you going to tell a grieving Black family, we're going to take this for research, right? What does research mean to them? So it is establishing that context of listening and understanding, and then trying to turn that into the benefit for society as a whole in organ donation. And it is a very tricky thing to do when there is so much grief and anger and hesitancy and distrust. We have come a long way, but there's still a long way to go. And very much what Linda said, when our clinical recovery coordinators are working on a case with a patient who has passed and their family, we're going to try and match those families up demographically, age-wise. If we need Spanish speakers, we'll make sure to have someone who speaks Spanish. We do try and match that up because it's true. It does. Some of our African-American families are going to want to speak to an African-American coordinator. That's just how it is. And we have to understand that. And that is part of the trust. If you want to talk to me, we'll find somebody who you can talk to, who you do trust.
Lesley, I believe also in this is ethics. Tuskegee experiments happened because of the lack of ethics that exists. And so, Linda, if you were going to look at this and talk to Lesley about the best ways for the DEI of it all around the ethics of transplant, what would be the language? How would you convince this generation who knows the long history? I mean, everybody feels it, not just African Americans. A lot of people of color feel the exact same way. Linda, what would be your response to that?
Okay. So just in case, because I know we're using the acronym DEI, just in case some people don't know what
Diversity,
that is.
Equity, and inclusion.
Yes. Okay. I think when we start looking at ethics, it's kind of multi-layered, because ethics can also be tied to religion as well. So if we talk about, and this is, and Lesley, we've had some conversations around this with your work with Muslim Life Planning Institute, so it's not just African Americans, but sometimes people have religious objections. And those religious objections are based on their ethics. And so what they're understanding in terms of what those ethical guidelines are. So some of that might be having the right resources available. And that may be, making sure that when it comes to ethics questions, that the organ procurement and donation community has those resources. Is there a trusted member of the community that you can reach out to talk to the family? Mm-hmm. Is there an imam that you can reach out to talk to the family to be able to give them that guidance? If there's issues and you start talking about African-American community and there's members of the African-American community saying, I don't know, I don't trust this. Is there a resource? And that might not be your coordinators. It may be some other individuals that has that trust relationship with the community, because the trust doesn't just come based on melanin. So there's a lot of things that go into the trust factor. So one of the things I would say is basically expand your relationships. Yep. Expand your relationships in the community with trusted members of the community, and that those are relationships that you have prior to when you have to pick up the phone. And that way you can begin to understand, what are some of those concerns and how do we now begin to address those concerns? What resources do we need? What people do we need? What documents do we need? What is it that we need in order to be able to address these concerns? Because Joya, you're right. It's not just African-American community. It's communities of color. There's people who are going to object, from a religious standpoint. And how do you begin to address these? And I think that is basically building your relationships, building your partnership, expanding your team.
Yeah, and that is absolutely correct. And you think about building that infrastructure, because you need to have that infrastructure there at that time, because things happen very quickly with organ donation, right? Yeah. Hollywood and TV has not done service at all to our industry. They perpetuate so many of the stereotypes, and it's been a really big problem. Hollywood, Grey's Anatomy has just been the worst for sort of communicating what organ donation is. But the part that they do get right is things do happen very quickly. Mm-hmm. So we can't build that foundation and that infrastructure in that community in real time right there with the family. It's our job to build that infrastructure, reach out to those partners, have that trusted voice available and on the ready for when it's time to talk to the family. We can't build it right then and there. We have to have that first, because things move so quickly. There are people on the waiting list that have days to live, right? So it's making sure that is done before. And that's how we service and show respect to our families, that we have these resources. We have built this for you. We are here for you.
Okay. Thank you very much, both of you. Dr. Carrese, you teach at the Berman Institute of Bioethics at Johns Hopkins. Could you tell me a little bit what ethics means to you as a doctor and at Johns Hopkins and how it's taught?
Sure. So, the teaching that I focus on is clinical ethics. Bioethics is a huge field, and there's many subfields. Clinical ethics is one of them. There's research ethics. We've been talking about research ethics a little bit with Tuskegee, and there's many other examples of terrible transgressions in the 20th century with research ethics. There's global ethics, food ethics, public health ethics, which has been in front and center during the pandemic. So lots of major subfields. I do most of my teaching in the area of clinical ethics because I'm teaching medical students and residents who are interacting with patients and family members. I think one of the major points we try to make when teaching is the importance of having a sense of the moral and ethical dimension of the healthcare professional-patient relationship, whether you're a doctor, a nurse, or a social worker, that it's a central part of every interaction. This isn't something that you once in a while have to think about when there's a crisis or a conflict or a dilemma. it's part of every single interaction. Every interaction involves responsibilities and obligations I have to my patients. It involves my values and their values, and that's all in the mix every single time. So it's not a side issue. It's a core central part of every interaction, every relationship, and that's the starting point for our teaching. And then, of course, we get into more detail about some of the things I mentioned earlier. It's the importance of respecting people and respecting their dignity, and how do we think about that in a diverse society? The importance of attending to people's benefit and protecting them from harm, and how do we think about those issues in a diverse society? And increasingly, the importance of justice and fairness. And we've certainly been reminded during the pandemic of how segments of the population have been disproportionately affected by the pandemic because of historical and structural injustice. So predated the pandemic, but the pandemic has reminded us. Certainly one of the hardest hit communities early on was the Navajo reservation. We saw scenes coming out of Gallatin, New Mexico, of them being completely overwhelmed. The Latino community, the African American community, communities that have been hit hardest. And that certainly requires us to think about justice and fairness and how to address that in an ongoing way.
Dr. Carrese, Johns Hopkins, I have one more question for Dr. Carrese, if you don't mind.
Sure.
Dr. Carrese, Johns Hopkins has built a reputation for being a very fine hospital, very fine research place, teaching hospital. But Johns Hopkins Hospital sits in one of the most underserved communities in Baltimore. And I'm wondering what the hospital feels its responsibility is to the overall community, not just the ones who line your emergency rooms.
Yeah, so I mean, I'm actually physically based at the Johns Hopkins Bayview Medical Center and do a lot of teaching on both campuses. But I think both the Johns Hopkins Hospital and the Johns Hopkins Bayview Medical Center feel very strongly that they absolutely have a commitment to the communities and have to do a better job than they've done historically in addressing community needs. We have a program at Johns Hopkins Bayview called Medicine for the Greater Good. And I think the leader of that, Dr. Panagis Galiatsatos, has been a presenter in the Life Planning Institute's programs in the past. But that's an explicit effort to reach out to the community and work with the community and listen to the community to address their needs. And I think, similarly, the Johns Hopkins Hospital has made efforts in that direction as well. One of my colleagues, Lisa Cooper Patrick, leads an effort on addressing inequity and disparity in health. A number of the faculty members who work in general internal medicine do community-based research, so incorporating community members into their work. Mm-hmm. And so I think this gets back to something that Ms. Howard said earlier about institutional trust. So, I mean, I can have a relationship with my patients and I may have behaved in a way over time to earn their trust. But if I'm not there when the organ needs to be donated, they need to be trusting more than just one or two people in the institution. They need to have trust at the institutional level. And so I think this is a crucial issue. And how do you build that over time? One of my roles is chairing the ethics committee at Bayview. And we had an opportunity a few years ago to work in the direction of having the institution get behind an effort to provide immigrant communities who are at risk for detention or deportation information about their due process rights. And I think by taking that effort and providing that information, it was a concrete, tangible evidence of the institution having the community's back and trying to build trust with the community at a moment of what could be major crisis for those families.
Mm-hmm. Thank you very much. Linda, I think you were chiming in for a moment there.
Yeah, I also want to say, to Lesley and kind of building on what Dr. Carrese also said, is that, with that trust, it's also not just at that point of when you're approaching individuals in terms of about the donation of organs. I recently did a presentation around bias in technology. And one of the things that I came across was some of the bias that's used by in the technology that may be used by physicians to even determine who should be on the list. So some of that work has to start beforehand, because I believe some of the hesitancy as well is not just, you just want my organs, but it's also, you just want my organs to give it to people that don't look like me. Mm. So also whether, is there a trust that there's fairness and ethics involved in the whole selection process? So it's not just is there that trust at an institutional level, but it's also, is it that trust at an industry level? Right. And so I think you have to look at the whole industry. And I just, Dr. Carrese, I loved, that approach in terms of supporting them with respect to deportation, because sometimes that trust is not necessarily tied to the medical issue, but it's, are you somebody that just has my back? Do you have my best interests at heart? Kudos on that program, because I think that's excellent.
Yeah, we're going to move to our next segment, and thank you everyone for that contribution. And our next segment is about the vaccine. There has been, as we all know, a trust and ethics question around this vaccine, around the pandemic. There are people who believed it was man-made and put into the society on purpose. There are people who believe that, I remember in the beginning, because the reported numbers were low around African Americans, that African Americans were immune to it. And then there was African Americans were targeted, and then old people were targeted. And then we come with the vaccine nearly a year ago. And now the debate is, should you get it? Should you not get it? If you don't get it, you don't get your job. You can't keep your job. If you do get it, you're not protected. So around trust and ethics on this vaccine, I'm going to start again. I'm going to start with Linda about the diversity, equity, and inclusion around the vaccine, trust and ethics. Can you respond to that?
Yeah, I can respond to it. The challenge is responding to it and confining it.
You're going to give us cliff notes.
I'm gonna have to because that's a whole nother session.
That could be a whole show. That could be a whole show. Yeah.
But I think that there are some serious, like if we just talk about the issue around people's jobs being contingent upon them taking the vaccine. I think, and I've had this conversation with a few of my clients around, when you approach that, you have to approach it from a diversity, equity, and inclusion perspective and a multicultural competency perspective, because it's a lot of organizations are looking at this as kind of a one size fit all. I was just on the phone with a client this morning, and we got on the topic around vaccines. And this happens to be someone of African descent. And she said, I'm glad my organization has not required me to take the vaccine yet. She says, I'm not taking it, not because I don't want to take it. She said, because I have some health conditions, which doesn't allow me to take it. Mm-hmm. And then she talked about that she's lost 5 family members to COVID. And none of them were interested in having the vaccine because of trust issues. And so, again, you can't mandate trust. So you can mandate that you can take the vaccine, but you still can't mandate the trust. And I think that some of the organizations' approaches are eroding the trust even further, because they're not taking in consideration true fares that as Lesley said, it's based on something. these are not fears and trust issues that's being pulled out of the air. It's based on something. And there may be people who have religious objections. There may be people who have health reasons. And so not taking all of that in consideration, I think is problematic. And I know that a lot of that we're in a place where there's just a lot of fear, and a lot of the responses are based on fear, and they're not the least intrusive approach to achieve the goal that's being sought.
And I think some of the fear is on both sides. There's fear.
Yes.
There's fear for those people who have taken the vaccine, associating with people who haven't, and people who haven't have the sort of fears that you just laid out. And then there's conspiracy, and there's political, and if you support this politician, then you don't take it. You support this politician, then you do take it. It gets really complicated. But Dr. Carrese, I want to turn to you for a moment, because on a personal level, the people who I know don't want to take it because it's not actually a vaccine, because it doesn't have a live virus. And for your patients, and then you're working in the work you do, how do you address that concern? That this is a man-made something that is being injected, and people are saying it's changing your genetics, and there's a lot of information out there. I'd like to hear your response.
Yeah, I mean, I think it's a huge challenge. The access that people have to the internet and all sorts of information, a lot of which is completely inaccurate, and instilling people with fear, and how do we overcome that in the context of a starting point where people don't trust the government, they don't trust their institutions, they don't trust the experts, they're skeptical about science. I mean, all of those things need to be in place for this to work, and for us to have a sort of an effective public health approach to the pandemic, which has killed 700,000 Americans at this point. So it's a huge challenge. I mean, there are facts and there are misinformation about the vaccine. I mean, the technology is actually not that new. It's one of the first major times it's been utilized to create a vaccine, but the technology has been worked on through NIH-funded research for many, many years, if not decades at this point. And this vaccine works like a lot of other vaccines that people don't object to and take all the time. And one of the more senior physicians I know at Johns Hopkins said, if you had to pick one innovation in the history of medicine that has been most effective, it's been the development of vaccines. And look at how we've all benefited from not having smallpox, polio, or childhood diseases. So I think overcoming all of that is a huge challenge. I know that I can say, at the individual physician level, I'm available to talk to my patients and listen to what their questions are, and hopefully address their fears. And and in the context of that trusting relationship, I don't think there's any person in my clinical practice who's come to me with questions and skepticism about the vaccination who hasn't eventually got it, based on that conversation and my recommendation, genuine belief that it's in their best interest to do it. But I'm one person, and this is a much bigger problem than that, and it gets back to trust at larger levels than individual people. But I think part of the solution is having a relationship with a healthcare professional, that somebody you trust. That's certainly one place to start.
I think some of this is ethics too. People, this is a question for everyone, it's ethics also. There are people who believe that taking the injection of the vaccine, somehow, ethically, we're going to pay for it in some later time. Ethically, I guess primarily Linda and Dr. Carrese, but Lesley, please chime in. Ethically, how does medicine, those who serve people in the health community, convince people that ethically you're not out to get us?
Can you just clarify? I'm not sure I completely follow. Who's not out to get who? That medicine, the government, or whoever, the FDA.
has not created this vaccine, has not created COVID and a vaccine, but primarily the vaccine to come get us later. That this was some injection that later on we're going to have some level of mutation that ethically, I guess this is my question. Ethically, you are here to protect us. How do you address that? People are saying your ethics aren't in place and they're fearful.
Well, I think it's not just about you're out to get us later. I think there also is some concern is have you done the work to ensure?
Because it came around really too fast. Is that what you're saying?
Well, yeah, maybe it may be, and sometimes it's not too fast. I mean, because if we just look at the medical profession, there are a lot of drugs that are FDA approved that later that we find that they have serious side effects, which is why you see all those commercials that say, did you take this drug between that time, and now you're experiencing this?
Yeah.
Oh, 1-800 lawyers, you know? So I mean, I think that, some people have concerns about whether or not this is going to be something that we will see side effects from down the line. One of the questions that I have, and this is, from a public health perspective, there's a lot of conversation about you can go get the vaccine for free, but there's no conversation about healthcare coverage should you experience any complications from the vaccine. So the vaccine is free, but if you suffer any complications, I don't think that there is an insurance that covers complications connected with the vaccine, because sometimes those complications might be 2 years down the line. So I know there's also, so you have whole communities that become vulnerable if they're uninsured or underinsured, and then there are some complications. So it's not just you're intentionally out to get us, but are you going to look out for should we have? That could only be 2%. That could only be 2% of the population that experienced a complication. But if you're that 2%,
it's devastating. It's definitely devastating. Yeah. Dr.
Carrese, we're having it. If I can chime in.
Please, yes.
Yeah. The donation and transplantation community right now is struggling with a ethical dilemma. There are transplant programs. So just for the audience to be aware, I work for an organ procurement organization, which is a separate nonprofit entity separate from the hospital that works with the hospital to facilitate the donation process when someone has died. On the other side, there are transplant centers. Those are the folks that list their patients, okay? So if I have chronic kidney disease, I'm on dialysis, and I'm listed for a kidney, I'm working with my transplant team, right? So these are also the teams that list their patients, and there are programs across the country now that are instituting a policy that patients who want to receive a transplant and be listed must have the coronavirus vaccine, or they will be taken off of the list.
Wow.
So that is a current real-time situation that has unexpectedly sort of popped up. And talk about ethics, there are boards that discuss these things, and there are boards that decide who's listed based on a number of factors. But that is getting a lot of press. People are starting to talk about it and saying, well, if I'm not vaccinated, then I'm going to be taken off the list. There are very valid reasons for that decision. But it is a interesting thing that has reared its head to discuss ethically.
Dr. Carrese, what is Hipaa?
Can I answer the vaccine question first?
Yes. I'm sorry, because yes, please answer the vaccine question.
HIPAA is largely about privacy, but I'd like to.
It's about privacy. That's all I needed.
Yeah, I think, as time passes, there is more and more data every day to answer the questions and the concerns about the vaccine. I mean, this is largely, as we're all seeing now, a disease of people who haven't been vaccinated. There's almost nobody in the hospitals now, in the intensive care units, intubated and dying, who have been vaccinated. There's a rare breakthrough case, but the vaccine is incredibly effective. I mean, it's outperformed all expectations, and that, you don't have to trust anybody about that. You can look at the data on the Johns Hopkins website that shows who's hospitalized now and who's dying. It's people who have not been vaccinated. And I think in terms of the safety of the vaccine, it, again, incredibly safe. There's rare side effects, but the vast, it's one case out of a million or something like that. Whereas the chance of dying from COVID is much, much higher. So the risk benefit trade-off there totally is in the direction of getting vaccinated. If it was an inside thing where we're doing something with the vaccine and you'll pay for it later, why would 90% of the staff at Johns Hopkins get vaccinated? I mean, the rate among vaccination among healthcare professionals across the country is extremely high. And that's because we believe in science and we're doing it to protect ourselves and our family and our patients. I mean, I've considered it a professional obligation to be vaccinated so that I don't transmit it, inadvertently to any of my patients. Many of whom are older and more vulnerable from a health point of view. So I think, there's a lot of, I understand, noise out there and a lot of misinformation, but I think if you just look at the data and the my patients early on, very early on, when they were skeptical, one of the things I would say to them, well, I'm your guinea pig. I got vaccinated. Let's see what happens to me, and we'll talk about it in a couple of months.
Right. Let me just say also too, because I've heard a lot of the concerns, and some of the concerns also is, how much, because you can have a different impact from given your genetic makeup. So what effect the vaccine might have on you, Dr. Carrese, may have a different effect on me if I were not significantly represented in the trials, for one. So I think that's some of the concern. And in doing DEI work, you work with data. And when you look at average numbers, sometimes it can look really good until you start breaking it down and saying, what about the subgroups? How did the subgroups get impacted? And I don't know the answer to that, but I don't think a lot of that information is being communicated. And then the other thing is that because this we don't have long-term studies, so there may not be any immediate side effects. And so you have people who are concerned about long-term side effects, and no one has the data on that because it hasn't been around long enough.
Totally agree.
So we don't know the effect 5 years down the line. We just know they got a shot right now. We didn't see any side effects, and the numbers are showing that you're better off if you have it than if you're not. If you don't.
Totally agree, and we're all in that same boat. But the other part of that boat is that's not a consideration in isolation. The other thing you have to consider along with that is people are dying from the infection that the vaccine is intended to protect you against. And again, it's doing a tremendous job of preventing those hospitalizations and deaths. We can just see it. Every hospital that's filled with patients right now, it's almost nobody who's been vaccinated. So I agree with you that that's one of the challenges in clinical medicine, every aspect of clinical medicine. And this is just also the case. We have to make decisions sometimes in the face of uncertainty. We don't have a crystal ball. We don't know. But the FDA has a very rigorous process for emergency use authorization. All of the vaccines pass that, and now they're getting to full authorization and booster shots, and that those processes are in place for a reason. And so far the vaccines have been passing all of those hurdles.
Right. Well, we have a couple of questions from the audience, and let me get to those right now. Sharon Abdullah says, good afternoon. Can the ability to empathize with others be learned, or is it innate?
I think, can I go? So I think that's a great question. And I think it helps. I would say both. And I would say in the teaching we do around ethics and virtues and empathy and listening, I think if you're a nursing student or a medical student or a social worker and you've got that innately, you're further ahead. But we also believe some of these things are skills that can be taught, both in terms of content and practicing. When we're working, for example, with residents on breaking bad news, like disclosing a new diagnosis of cancer, there are things that you can say that are and sound more empathic, and things that you can say that don't come across that way to patients. And so we spend time trying to teach that and practice that, working with standardized patients. So great if you've got it innately, and that's probably the best way to have it, but we will also work on trying to teach you how to do a better job of it. But I would say, either way, really wanting to be empathic and trying to be empathic and having that be at the core of your being can be sniffed out by patients, I think. Acting empathic doesn't really work.
That's why I think it's innate. They can smell the BS meter sometimes. I think it's very much innate. Yeah.
But I think it's also, if you're talking about it in the context of like healthcare and in institutions, organizations, I think it's also important for those organizations to have the policies in place, the protocols in place, the training in place, because sometimes even when it's not there, and it's acting is better than not acting. So it's the same thing. Like I say, you can't legislate racism out of people, but you can stop them from behaving as racist through your policies in an organization. And so I think that there are some things that I don't know whether you can teach it or not, but I think you can put protocols in place to allow for people to behave in a more empathetic way.
That leads us to the next question we have, which will be our final question, because unfortunately we're getting short on time. The question is there room for a patient bill of rights, which would include the right of respect, privacy, patience, truthfulness, and humility?
Well, we have a patient bill of rights and responsibilities at both the Johns Hopkins Hospital and the Johns Hopkins Bayview Medical Center. And it includes most of the things that were just mentioned. It also, one of the reasons I'm familiar with it recently, because we've encountered a problem, in the last few years because of national rhetoric, where some patients are being prejudiced and bigoted towards their physicians of female or color or diverse physician population in the Johns Hopkins health system. And so patients are attacking providers. And one of the things we point out to patients is that in the patient's bill of rights and responsibilities, we expect patients to treat staff with respect and dignity and civility. But it's a two-way street. We absolutely have a policy for both providers and patients that they're both entitled to respect and civility and dignity and being treated. Everybody treats everybody that way.
Right. Anyone else want to chime in? How would that help work, Linda?
Yeah, I think that there's definitely room for it. And like Johns Hopkins, I think most hospitals do have it. I think it might be worth, like, a part of when I'm looking at, like, doing kind of an assessment of where you are from a diversity, equity, and inclusion perspective. A lot of it is actually looking at those policies and those practices with that lens on. So I think looking at that patient bill of rights, it'd be worth looking at it and seeing whether or not it is multiculturally competent. Who is at the table drafting that patient bill of rights and what was being considered? Because oftentimes when you look at issues like trust and empathy and respect, what does that mean? And what does that mean from a cultural perspective? So I think a lot of organizations, I think that even though they have one, there's probably a lot of opportunities for improvement there.
Okay. Lesley, do you want to chime in on that for just a moment? Just a few words?
Well, I think we give our families, the donor families that we work with, the right to say no. We are not here to force, to push, to guilt, to make you feel bad.
Mhm.
We just hope for an informed decision. And you have a right to say no.
Yeah.
We want people to know that. Yeah.
Okay. Unfortunately, the hour has passed. And I want to thank each and every one of you, not just for being on our program today, but for the work that you do serving our community. I think each and every one of you is so important. The disciplines you're in are so important for our overall health in our community. And it's really nice to have a sane conversation about all the things we talked about today. So I thank you, each and every one of you, for doing this. I thank everyone who is watching, especially those audience members who sent in questions. And I'm sorry I didn't get to all of them, but the conversation was going so well. I missed some of the questions. So please forgive me. It was my head, not my heart. So I want to thank our producers and everyone who pulled this show together for the honor of being here. Peace and blessings to you all.